Welcome to the NewlyMeds Podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another episode of the NewlyMeds Podcast. And happy holidays. Happy December. Now, Thanksgiving's passed. Dan, how's everything going for you?
It's been going great over here. How about for you?
You know how it is, keeping busy, but enjoying it. It's probably one of my favorite times of years, when the leaves kind of empty out and getting a little bit of snow now. Hopefully, I know you're probably getting a little bit, so always exciting.
We got quite a bit of snow coming up in the forecast here up my way, so I'm excited to get our first snow of the year for sure.
Perfect. Well, I know with the end of this season and the end of the year, we had something really special that we wanted to talk about on the podcast. And so today we're going to dive into a little bit of a year in review, not just a year in review for the NewlyMeds and what we've established just this year as a podcast, but really a year in review for medicine and paramedicine. And as a new provider, as someone who listens to the podcast, or even people that are experienced listening to the podcast, these simple things that we're going to talk about today are always important to carry with you throughout your entire career and duration in medicine, whether it be in EMS or in the hospital or whatever you decide to do. So, Dan, before I dive into it, do you have anything that you want to talk about? Kind of how we got to this point. I know bringing you on full time here on the podcast this year was a huge step for the NewlyMeds, and we've made some really big strides. Now we're putting out 2 episodes every month and have some really awesome things to look forward to in the upcoming year.
Well, and exactly what you said. I'm very proud of what we've accomplished so far, and I'm certainly looking forward to next year and what all that has in store for us there. And I think as we kind of start talking about some of these topics, it'll be a lot less focused on the heavier clinical stuff that we've been talking about in previous episodes. There will still be some clinical stuff, but as we're talking about some of these topics that are geared towards the newer paramedic or newer healthcare provider in general, exactly what Will said is this is something that we can be gauging as a new healthcare provider, but that we as experienced healthcare providers should also be gauging, maybe not necessarily on a yearly basis, but on a regular basis, to make sure that we are still doing the right things for the right reasons, and that we are keeping ourselves grounded both in our personal and professional lives with that. So I think just because some of these topics might be more specific towards new providers doesn't mean that these aren't things that we should be keeping in mind as experienced providers, and kind of having that self-reflection as well, regardless of our level of experience.
Absolutely. That's such a good point. And it really brings me into the first thing that I want to talk about with you today, Dan, and with all of the people listening and watching, is really jumping into a reality check in our year of review. So today we're going to talk about what it means to be, a paramedic, really, but anybody in healthcare can take away from this. And so I think what Dan said is so true. And I want to just jump into the start of it. And really, that's developing your clinical skills. And so at any point in your career, you really have to be humble enough to reflect back on to your own skills and comfortability, and even just things that are lapsing. Maybe you got really focused in a direction of medicine that took you away from some different skills. Maybe you worked in the pediatric population and now you're jumping back into a new job with adults, or maybe you've only ever done the adult population and now you're jumping into pediatrics. It's always great to reflect on some of the skills that you've acquired and the knowledge and education that you've gathered over the years, but then to take a look at where some of the flaws are, and always working on improving your craft and just sharpening yourself to be the best provider possible. And that leads me to the first thing that we want to talk about, which is your development in clinical and how you want to really establish yourself in healthcare. And so, as a new paramedic, I think that oftentimes, especially studies show, but new paramedics are going to rely a lot on vital signs, and they're going to be doing a lot of looking at the monitor, trying to gather as much diagnostic information as you can. And in EMS, we really have limited diagnostic tools, But we want to remember that we're not really always going to want to be focusing on those diagnostics. We've talked many times on the podcast. Some of the best tools that I have at my disposal as a paramedic is my assessment and the ability to assess my patient. And so understand that the pattern recognition for a lot of these presentations is going to take a lot of time, typically 6 months to a year. And you really have to start seeing similar presentations and different patterns as they emerge to understand them. And the best thing for that is to do thorough assessments on every single patient. Don't over rely on those vital signs. Get down and dirty and assess those patients. Listen to lung sounds. I cannot emphasize that enough on every single patient. I promise you, if you get really, really good at auscultating lung sounds, you are going to hear these very minute differences that might make the world to you between a patient who has, you know, really weak stridor and a collapsing airway or some minimal wheezing to the patient that's pending respiratory arrest. It will make a difference. So always just do a thorough assessment on every patient that you see in the field. Don't rely so much on becoming competent overnight. It's going to take some time. It's going to take a lot of patient contacts and exposure and doing the skills properly to gain that level of competence. And remember to always ask about documentation. Dan and I are going to talk a lot about documentation as we progress through this episode, but it's important to not over document or repeat your documentation, but document very thoroughly. And I think for me, the best thing that I learned with documentation was one, my own pattern and my own way of documenting something, but talking to people who have been in the field for a while. How do they work on reducing any redundancies and over charting, but making sure all the critical information is in there? And then always remember that your confidence is going to increase as you get a lot of volume exposure. So the more patients that you see in the field, you're just going to become more confident. I know we've talked on the podcast before, and I've talked to Dan many times about my trials and tribulations as a young paramedic. And I will always remember this respiratory patient that I had with a listener on the podcast who was training me at the time. My recognition wasn't great, but that's really where I got good at assessing patients. It's understanding that I'm not going to be very good at this right now. I've never seen this presentation before, so I may not know the exact treatment modality. I might have all the research and clinical and theoretical knowledge, but if you've never seen something and you can't recognize it, it's more than okay. It will come with time, and just be patient with yourself. Understand that when you operate as a new paramedic, it's going to be a long time until you get comfortable, 2 to 3 months at least. But I would say, and Dan probably also says, and Dan's been in this a lot longer than me, I don't think I'm ever really comfortable. I gained a little more swagger through the years, maybe a little bit more confidence on scene, but then you always get humbled, and you just remember that that's the field that you're in. As soon as you start getting complacent and comfortable, I think something's always going to humble you, and you sort of get yourself regrounded. So you may not always be comfortable, but just trust the process and trust that a little bit more comfortability is going to come with time. And in that first year as a paramedic, it's really, really difficult to multitask. I think that's what I struggled with the most, was understanding that I can and should delegate tasks. You oftentimes are going to have a lot of people on your team. Have them do things for you. You don't have to do everything, and be comfortable with the members that are on your team. Utilize them and really appreciate them. Obviously, every paramedic has to start out as an EMT, and maybe you were an EMT with not a lot of experience and went to paramedic school. Maybe you were an EMT with a ton of experience and went to paramedic school, but really appreciate your partners and your team in whatever operational capacity they're in, because everybody can help you do your job appropriately. And so no matter what their certification level is, they're all a critical part of the team, and use them because they're going to be your best friend on these really high acuity calls. And something, that I want to kind of close on before I pass the ball over to Dan, we're going to talk about it a lot more, but limiting your emotional and cognitive load. On those days off, don't worry about medicine so much. I think, Dan and I really, we eat, breathe, sleep medicine. We're always looking at studies and new topics, but have an outlet. You know, I love to go golfing. I love to go out and hike and be in nature. I have a dog. I think just anything that gets you away from medicine for a little bit is great. I love medicine. I love EMS, and I love learning. I went back to school to become a nurse. I'm a registered nurse as well as a paramedic. I love everything that medicine has to offer. And I will always go back for the extra education. I will always look at that new case study and appreciate it. But what I appreciate more is sort of the things that I get to do when I'm away from medicine. Being the best provider that I can, a huge part of that is having an outlet so that I don't burn myself out or overload myself cognitively. You can really love this stuff and you can eat, breathe, sleep, all of it. But at the end of the day, you got to have an outlet because it's non-sustainable. So don't always get tunneled in on that. Just focus on one problem as they come about and have an outlet, have a resource that you can go to, whether it's a dog, a friend, a sport, anything. You don't have to be doing this every living, breathing second of your life. It's really important to become a great provider by looking at the things on your days off, but don't let it consume you. And then adjusting professionally. At the end of the day, especially as a new paramedic, you're going from EMT to now paramedic, and you are it. You're the person that EMT looks to as, how do I do my job? You are now the professional. And so you have to really adjust to that. It might take some time, but with that's going to come more responsibility, more accountability. And so understanding that you're in this new role and sometimes you have to mature and grow up a little bit, and some things that maybe you got away with in a professional environment has to change a little bit because now people are looking at you as this higher person. And so adjusting to that professional ability and experience might take some time. So give yourself grace with that as well. So understand how to talk to people and how much talking is really needed on scene, and being in the forefront of care is really important to that professional adjustment, as well as the off the scene things, taking people under your wing, making sure your EMTs feel appreciated, making sure all those ancillary responsibilities as a paramedic are taken care of, because you want to make sure that you are that paramedic who has your job squared away tip top before you start telling other people to do something. Just take out the trash at the station. It's that one easy thing that garners you so much respect in the professional world, and people see you do it. Even if nobody sees you do it, people see you do it, and it will get you so much further. Dan, you have anything else with that? I kind of spoke for a lot there, but um,
No, I think the big thing to keep in mind, takeaway wise from the things you were talking about, we set timelines for ourselves a lot of times when we're transitioning into these new roles. I want to be comfortable with XYZ by 6 months or whatever the case may be. We try and set these timelines, but we do have to understand, Will, you said one of the most important things there, that it's not as much time. Yes, time is a factor, but it's overall exposure. If you are working for a slower system, that 6 months might realistically be 12 months. Or maybe you're working for a more IFT heavy service, and a 911 related goal, instead of 6 months might be 12 months, or whatever the case may be. But understand that it as much of the time component does exist, a lot of that goes with exposure as well.
absolutely. Dan, something that I want to ask you about, and I think we've both experienced it in some capacity, and I I think I start to experience it a little bit more, especially as I went back to nursing school with some experience under my belt as a paramedic and working in a critical care environment and understanding some things. But how do you manage imposter syndrome? And give me some advice because I'm kind of going back through it again, all over again.
Well, you are not alone in that. First of all, obviously, uh, some studies can say up to 65 to 80% of new healthcare providers, just generally speaking, can have some type of imposter syndrome. It's not uncommon. Actually, it's uncommon if you don't feel that at some point in time. I would say more realistically. I know me personally, I did have some instances of imposter syndrome going to a paramedic, but I would argue that I felt more imposter syndrome when I went from a basic EMT to an advanced EMT. And this is no slight. I think the advanced EMT, where it's gone and where it's going, is a fantastic thing. But switching from that EMT with essentially a national registry scope of practice to an advanced EMT, essentially national registry scope of practice, outside of a few skills, outside of a little bit more clinical knowledge, there's not a massive gap, or at least the same size of gap as there is from an EMT to a paramedic or even an AEMT to a paramedic. So I found a lot of times, especially right after I became an AEMT, was that you're still regarded, quote unquote, as a higher level of care than the basic, and you're still getting looked to, and you quickly realize, or at least you begin to feel like, I don't have any of these answers.
Mm.
And some of that might be perceived and some of that might be true. Um, but I think that was one of the times I struggled the most. And I've certainly struggled with this some too, when transitioning into a paramedic role. But when we think about this, especially in EMS, I would say we are some of the most prone outside of our higher level of cares. I'd say we are some of the most prone to this imposter syndrome because we have such a high autonomy.
Mm.
Yeah, we have our protocols and our guidelines. We have these parameters that we work within, but we have a high level of autonomy, and coupled that with a low immediate feedback. A lot of times we don't know the outcome, or if you have like an HDE and you just get the generic diagnosis. Like there's not a ton of feedback in a lot of systems. I know some systems have great feedback, but a lot of systems at this time really don't. Couple those two pieces with the fact that it is a high consequence environment. This is, not to be cliche and not to be dramatic, but it is a life or death scenario. A lot of these times, or potential life and death scenario, a lot of these times where you are sitting there on your way to this call and you're like, man, I just got out of a 1 year program 2 weeks ago.
Yeah.
Or I just got cleared to be on my own 2 weeks ago. I shouldn't be doing this. And that's not the case. We go through the work, we go through the training, we go through the credentialing periods, and we go through all of this work to get the privilege to be able to take care of people and take care of these patients in their time of need. But that really does breed an environment in which you can fall into this imposter syndrome. And I
Yeah.
think when we look at this, well, how does this present? What can you maybe look, if you're looking to your partner or if you're self-reflecting, what might this look like? One of the most important actions that we can look for is inaction or hesitation to act, because we're trying to make sure that we're making the correct decision. We're trying to make sure that we are performing all of the steps that we know we're supposed to, that we learned in school, and that we think that we are looking for. But this hesitation could potentially become an issue in
Mm.
that patient care. And a lot of times, some of the other signs we might look for: excessive post-call analysis or relying on your partners for reassurance. Listen, I'm no different than everybody else, same as Will. After severe calls, I know both Will and I will look to each other. Hey, how did I do? How did you do? What could we have done differently? There's a difference in debriefing versus relying on that partner consistently for reassurance, essentially for your existence, right? Debriefing is important. Going over the call, understanding what went well, what maybe didn't go as well as it should have. Those are all very important aspects. But depending on that partner, looking to that partner constantly for essentially their approval, or even the small things, that could be a sign that we're kind of having some of that imposter syndrome. Other things that we need to keep in mind is that before we find ourselves in this imposter syndrome, or if we're finding ourselves sliding down that kind of rabbit hole, when we're reflecting inward, what is it that we are afraid of? What it is it that we are feeling? Are we afraid that we're going to make a mistake that could cause harm? While that fear is a good thing, we do need to hold and harness some of that, because we should be using that to guide our decisions to make sure that we are making the right decisions. But an actual fear, again, leading back to that hesitation, where I don't want to do some type of action. I don't want to administer this medication, or I don't want to pull the trigger on this intervention because I'm afraid I do it incorrectly. That causes just as much, if not more, harm to that patient. Other things comparing, do you find yourself, oh, well, John would have done this differently on this call, and John's been doing this for 20 years. Yeah, he probably would have. He has his own flow. He has his own years of built pattern recognition that we simply don't have at 1, 2, 3 years that John does at 20 years.
Mm.
We don't need to prove our worth. We need to continue to grow. We need to continue to learn. And by doing so, that will essentially kind of lead to that self-actualization and realization within this position that, hey, I'm where I'm supposed to be, and I'm doing the things that I'm supposed to be doing, and that is providing excellent patient care. We have the background, and it's on us to then take that to the next step and deliver that care to that patient. Some of the things that I like to think of, Will, I'd be interested to see if you had any others to add. But some of the things I like to think of, and we kind of touched on this before, especially when kind of dealing with analysis paralysis and loop, like thought processing loops, is verbalizing these steps. Talk to your partner. I just yesterday had, or it might have been 2 days ago, irrelevant. Just had a call in which I was verbalizing everything to my partner, and they're kind of like looking at me like, why are we having this conversation? Is this is your job? And is yes, this is my job, but this is our job.
Mm.
You have been doing this job for years as well. You know what, even though you are an EMT and I'm a paramedic, you've been in the field, you know how these things go. And I'm making sure, one, I'm doing a self check essentially to make sure that as I'm verbalizing and making this list and going down this list, that I'm checking these boxes off myself. But maybe you hear something and say, wait, why didn't we do XYZ? Just because I'm saying it out loud and checking it on my own, that provides that second level right there. And that alone can be enough to kind of break that syndrome of being able to have that conversation. And I think most importantly, Will, I think we need to normalize this feeling. We need to normalize doubt. We need to accept the fact that it is okay. At the top of this segment, I've said we have we work in a high consequence environment with a high level of autonomy, with low feedback, high stress. There is good reason to have doubt and fear going into this profession and across healthcare, essentially, because we are doing just that. We are providing care for patients who are sick, injured, and potentially dying. The stakes are no high. There are no higher stakes than that. So I think it is okay to have these doubts, but we need to work together. We need to work together as partners, as stations, as a profession, as a whole, to work through these and build our young up versus tearing them down, which can be a whole other episode. But I think that largely plays into the imposter syndrome. Is while a lot of places are getting better with that, I would be lying, and I think Will would be lying to say that that doesn't exist anymore, because it most certainly does. And so I think that is something that we all need to be doing better with.
Yeah, absolutely, Dan. I actually, while you were talking, took a couple of notes. To jump back into what you just said, I think using those structured checklists and just verbalizing your steps to your partner is so important to reducing some of that analysis paralysis or the error that you might feel, but also the doubt. I think as more systems are going to maybe a medic workup or a chase medic workup with two EMTs that are on an ambulance together, or even the traditional MICU setup. When I still could work as a paramedic, but when I was working full time as a paramedic, I had an EMT partner, and a lot of things were caught or just sounded off when no, the EMT that I was working with wasn't expected to know what I was saying. But, especially on those high acuity calls, like, hey, I'm going to give another milligram of epi in 3 to 5 minutes. Does that sound right to you? And they're like, well, yeah, but it's been, 8 minutes, or yeah, but you don't even have IV access yet. It's like, as soon as I start thinking through my thought process, it's like, oh my gosh, like I missed something. And then, that's how things get caught and things get done and mistakes get minimalized, is when you just have that verbal vomit. Uh, I think that no matter your level of certification, your perspective is so important. So whether you're working with another medic and you're bouncing ideas off them, or whether you're working with an EMT, or even someone that's just on a ride along. Maybe they've never been in medicine before, never seen of it. Maybe they have no idea, but they watch a lot of Chicago Fire, or they watch a lot of 911 or something. Maybe they want to try something crazy. And those TV shows oftentimes don't really reflect the reality of things. But if they have an idea, I'm willing to hear it. Like, let's just try it. And I think talking is the first step to that.
Well, and to go on that, Will, for the new EMTs or even the experienced EMTs, I'll get to the medics here in a second, but to the new and experienced EMTs, even if you don't know what it is, or even if don't be afraid to say something just because you might think that you're wrong. I would much rather have an EMT say, "Hey, what do you think about a steroid for this patient?" And
Absolutely.
that is just completely not indicated in that patient, and we can have a conversation about steroids after. But what if that was indicated and my mind was just completely somewhere else, and it's like, "Oh yeah, that's actually a really good idea. Let's do that." I think even if you don't know what the medication is, a simple comment of, "Hey, is there any medicine that we could give?" Or, "Hey, is there any other intervention that we could do?" Or something to that effect. I think we as EMTs, newer, experienced, need to be in an environment in which we feel safe, and not only safe, but encouraged to speak up. And medics, we need to do better to provide that environment.
Yeah.
We need to do better in creating that bond, creating that atmosphere in which this relationship can flourish and can actually prove very fruitful.
Yeah, I think you're so right. And the other note that I made was having someone in that environment, sort of what you said, to keep you grounded, but also to tell you when you're wrong. Because in that environment that builds trust and inclusivity and makes you feel safe, it can't always be the reassurance. Yes, you did this right. Yes, you did this great. But the person that trained me listens to this, and I know he's watching. I could never do something right, even when I was right. He always kept me grounded because he knew me as a person. And like everybody loves to get the ego stroked. I always would look for it from him, but he also knew how to keep me grounded. On those critical calls, he would tell me what went right, and then he would tell me what went wrong. And it made me a way better provider. And I think just having that environment that feels safe to you is the most important. So medics that are training and precepting, whether you're training an EMT or a AEMT or a medic student or a medic that's on orientation, foster that inclusivity, make them feel safe, make them feel welcomed, make them feel like they can make a mistake and that they should make a mistake. This is medicine. We're practicing it. Mistakes are going to happen all the time. The important thing is that they learn from it and that they feel safe being able to make that mistake. It's okay to be wrong. And having someone to tell you when you're wrong and why you're wrong so that you don't make the mistake again is the most important thing. And you have to feel safe to do that. And that leads me into the next thing that I want to talk about here with the year in review of paramedics is some of these hard topics, and that's the airway. And so, a few things that I want to jump into as we're talking about making a safe environment and these really high acuity calls. EMS is constantly growing and expanding, some places faster than others. And with that, I know a lot of the viewers and watchers today already probably have RSI medications on their trucks, already have blood products on their trucks. And I think one of the most important things as a paramedic and one of the very critical interventions that we do is airway management. And I sort of alluded to it earlier when I talked about this really sick respiratory patient that I had that jump started my passion for respiratory. But I really didn't know what I was doing. And I think the most important thing as we progress and get these advanced medications is not just when should we use them, when should we not use them? taking an airway is really something that you can't go back from. As soon as you push that paralytic, you need to establish an advanced airway. There's really no other option. And those who have RSI medications understand that. You go through extensive training, you recognize patterns, assess airways, and you hopefully know when you're going to take an airway, but really when you're not going to take the airway. Some of the things that I think as a brand new paramedic I missed and that a lot of paramedics miss is the basic stuff. I was an EMT for quite a bit of time before I went to paramedic school. And I can say with definitive certainty that OPA makes the world of difference. I have not needed to intubate patients because of good head tilt chin lift, jaw thrust, and an OPA and high quality BVM ventilations. I've recovered airways with that without ever having to take it.
Well,
So
when you say high quality BVM ventilations, care to allude or build on that?
yeah, absolutely, Dan. Something that I did recently, actually within the last week, was take a ATLS class, Advanced Trauma Life Support. I think, and I may be speaking out of tone here or anything. I think it's the highest level of trauma life support that you can get. It's sort of a class that's reserved for physicians and APPs, but I would encourage every paramedic to take it. I would encourage anybody to take it. I had no business being in that class, but I wanted the knowledge, and it was hard. There were things I've never done, putting in chest tubes and all that. And every person in that class was a physician or a provider. And the thing that I took away from it was the BLS intervention saves you from everything. And so when I say high quality ventilations, I mean getting a good seal with that mask on the face. If you have the ability, two-person technique, one person is sealing that face mask to the patient and the other is squeezing the bag. And not only that, squeezing the bag with the appropriate volume. I think, as we progress, we're getting smaller bags because we've over ventilated a lot of patients, but you don't really need to squeeze that bag the whole way. Squeeze it a little past that chest rise and fall, or just until you get the chest rise and fall, but understanding that people have a different body habitus. So try to evaluate that person. Just because they're larger doesn't mean that their, lungs are larger. Someone who's has a large body habitus but is 5'5", those lungs are going to be the same size. That's why we go off the ideal body weight for a lot of respiratory interventions. But you don't need to squeeze the whole bag, and just try to get a good seal on that face and open the airway appropriately. That head tilt shift, chin lift, or the jaw thrust, making sure that that airway is open, that tongue is displaced, adding that adjunct and getting the seal and the appropriate squeeze on the bag is the most important thing. Did I hit that a little deeper for you, Dan?
Yeah, absolutely. I think we all hear that. We all know that it's true. I had not had the opportunity and the privilege to go to a cadaver lab until pretty substantial amount of time into my career. And it wasn't until I was in a cadaver lab doing airway maneuvers that I truly, genuinely saw the difference in what we consider fine enough with our little EC one-handed, kind of holding on, barely holding on, giving the bag a squeeze, and what a good, true two-person BVM maneuver actually does versus what we end up doing a lot of times is really not doing. So yeah, I think we hit the head on that. I know that's not a widely super easily attainable experience to go to a cadaver lab, but if that is something that you do have the opportunity to do and you can do so, I highly recommend doing that because you do get to see a lot of these things from an inside out perspective, and that really genuinely puts a new perspective on a lot of these procedures.
Absolutely. Continuing down that airway trend and the use of cadavers and some different tools that we have, maybe, not at exposure with the cadaver, we might not have the ability to do that, but something that every EMS provider has the ability to do is end title. I think using your end title on a lot of your respiratory patients, I think using your end title on, I don't want to say every patient, but a lot of patients, it can provide you so much data. And I know, you know, things are not free in this life and people have to buy them, and using one of these things on a patient might again cause system maybe shortage or something like that. But in an ideal world, I think that every ALS patient can benefit from the use of end-tidal CO2, but especially when we're talking about advanced airways, it's going to be your definitive in the field confirmation that that airway is good is using that end-tidal CO2. I did realize that it is not the actual definitive determination of whether the airway is good in the ATLS class. That would be a chest x-ray showing that the ET tube is just above the carina, which was a tough question to answer after many, many years of being told that end tidal is the definitive answer. But I had to kind of reorient myself to this class is physician geared and that I do have a chest x-ray at my disposal. In the field, we don't. End tidal is going to be the definitive answer. And it's an awesome, awesome tool. And then I think a few additional key takeaways with the airway as a brand new paramedic is trying to just re-ground yourself to the situation. I think that so many new paramedics have these collapsing airways and they just want to get air into the patient. And we are doing so much more harm when we're doing that. We're overventilating and hyperventilating these patients, oftentimes more than 20 times in a minute. And really, we're just causing unnecessary trauma. We're causing barotrauma, especially if we have an ET tube and we're just pushing a lot of air directly into the lungs, but also if we're just using a basic adjunct and a BVM, we're going to start to overventilate a number of things. We're going to overventilate the lungs and we're going to push a lot of excess air into the abdomen and the stomach. So optimize those airways with positioning, calming yourself down, not hyperventilating your patient. I can't say enough good about it, and using that end tidal. And then one of the last things that I want to talk about in airway is probably the best thing. And if you're going to take anything away from this segment, it should be this. When I first was taught to intubate, the person that trained me told me to hold my breath. And you'll probably see that as a consistent theme through a lot of experienced medics. I think they all tend to say it, but mine really made it a point, especially because when I was a brand new paramedic, we didn't have video laryngoscopy. We only had direct. You were up close and personal. It definitely was not as easy as it is now with some of these contaminated airways doing direct. The video and suction and decanto suction has made intubation a lot easier, which is good. I'm not saying that it's easy at all. It can obviously still be very difficult, but we have so many tools now that really help us as providers so that we can establish that airway. And that's the most important thing. It doesn't matter how you do it. It just matters that you get it and that the patient wasn't hypoxic or hypotensive during that attempt. But the most important piece of advice was to hold my breath. The person that trained me told me to hold my breath while I was intubating the patient because as soon as I can't breathe anymore, the patient can't breathe anymore. And along with that is the oxygenation. So try to keep your intubation attempt short, less than 30 seconds, because that patient is going to become hypoxic very fast. And always pre-oxygenate your patient. Before you intubate them, take the time to bag them, build up that oxygen store in the body, give them as much oxygen as they can, flush all that bad stuff out of their system, give them 100% oxygen because you're going to have them apneic while you're intubating them. And if you can, one of the things that I love to do, and Dan knows it, is when I intubate a patient, I put a nasal cannula on them during the attempt. I put it on before I bag them. They get a nasal cannula opened up all the way. It's not going to hurt them, I promise, as long as I'm not running it in there for 3 hours in a row at high flow oxygen through a normal field nasal cannula. Shouldn't do anything bad. I just want to keep their oxygen stores up while I'm doing that intubation. And that nasal cannula is a bridge for me between the BVM and the ET tube that keeps that oxygen going into the body.
And that is for our friends and folks that does not have that in their protocols. For example, the service that I work for now, that is our standard protocol to do that. I know where Will and I both used to work, and in the state that we used to work, that was not in the statewide protocols. So for those, if that's not something that you have in your protocols, that it should be, and that should be part of your practice. Absolutely.
Absolutely. And I think the research shows that, and that passive oxygenation during the attempt, before the attempt, all of it just has so many good outcomes. And we talk about, the dash 1A intubation and all the fancy lingo. Really, all that matters is that you can get that tube in the first attempt. Hopefully, that's the goal, is a definitive airway without hypotension or hypoxia on the first attempt. That's what I would consider, and what nationally is considered a good advanced airway, is that you can do all that. But at the end of the day, if it takes 2 attempts, if it takes 3, please oxygenate that patient. Don't take forever to intubate them. Hold your breath while you do it. Give them some breaths. If you don't get the intubation, bag them, rebuild that oxygen store, and then get your second attempt, your third attempt, and try to minimize that airway trauma and set your ego aside. If you can't get that airway, again, maybe you don't have VL at your service, maybe you only have direct. There's always going to be a higher level of care in everything, even in the hospitals. There's a higher level of care. That's the way medicine's built. Put in a basic adjunct or an intermediate adjunct, whether you have an IGL or a King or something. If you can't get that ET tube, try to bridge that gap between here and that higher level of care that maybe they have a video scope and they can help you. And don't be afraid to call for help. If you're struggling, call for another medic, or call for, if you're on a medic truck, maybe have your partner take a look. Try to minimize trauma to that patient and minimize hypoxia. Anything you can do to get that airway is what we should be doing. Dan, it's December. We just sort of talked about the airway. It's cold. It's flu season. I just got my flu shot a little bit ago. Winter is weird.
Yeah.
What the heck goes on with medicine in the winter? Because I feel like in the spring, in the summer, I get a lot of trauma patients. I see a lot of different things. And in the winter, as we're talking about respiratory stuff, I start to see some funky things going on. I start to see some weird vent settings. I start to see some weird presentations of patients with respiratory pathology that I just can't figure out. What's the deal with winter, Dan?
Well, absolutely. And I think we're going to kind of keep these very, very brief. These are kind of all different ideas that we had for an episode, or at least a quick crit episode that we just, it's December now. So we ran out of time for this year. But we did
Sure.
want to at least in some rapid fire fashion throw a couple of these winter related things out there to keep in mind as we're approaching the winter season, what we could see both from an environmental aspect and a pathophys aspect. So first thing I want to keep a lookout for, while this can happen at any time of the year, with winter and using heat sources, carbon monoxide poisoning. Can look like a flu with no fever, can be vague symptoms, but keep in mind history is super important for these. Keep in mind that CO is binding to the hemoglobin 200 times more. It has a 200 times higher affinity than oxygen does to binding to the hemoglobin. Remember, I know we all get drilled in our heads in EMT school. Pulse oxes don't differentiate between oxyhemoglobin and carboxyhemoglobin. Make sure that if you have the special carboxyhemoglobin monitor, that we're using that where this might be suspected carbon monoxide poisoning. And high flow oxygen, transporting to the most appropriate facility. If it is some type of significant exposure, maybe bypassing the local to go to a hyperbaric capable system. But regardless of where our transport decision is, make sure we're giving them high flow oxygen. They need high flow oxygen. That's decreasing the half-life from potentially up to 240 minutes down to just over an hour, somewhere between an hour and an hour and a half. So over half of the time we're decreasing on that half-life with that high flow oxygen flush out to make sure that we are delivering that. Well, I do still want to get to a whole episode dedicated to winter respiratory trends,
Yeah.
but just for a real quick rapid fire here, we all know this, but we do see a viral spike in the winter just based on both environmental conditions. So we're indoors more, the air is more stagnant. We are more in more crowded areas indoors for longer periods of time due to the weather. This can also spike COPD exacerbations, CHF exacerbations. Specifically with CHF, we can see decompensation in the cold weather due to an increase in the afterload. We can make sure that we are doing what Will said and utilizing end tidal for these patients, but make sure that we are paying close attention to what these respiratory patients are telling us from a physiological standpoint. Also, another one, our kiddos, looking for croup, looking for those other types of respiratory infections that, again, we can see other times of the years, but they are going to hit the hardest. And also, all of our friends from the South, who don't know what we're talking about, come up north and see me, and we'll talk. Um, but so cold exposure and frostbite, just some real quick with that. When we get cold, what do? We rub our hands together. Make sure that we're not doing that for our patients, or we're discouraging our patients from doing that when they do have frostbite. Yes, that does create a heat reaction if the skin and tissue is otherwise healthy and not injured. But frostbitten tissue, that's going to increase damage at a cellular level. We want to make sure that we're avoiding that. Early frostbite is going to start with numbness and discoloration, and we know that that can go all the way up to potential loss of limb, right? So we have our kind of just like with our burns, we have our superficial, our partial thicknesses, and our deep. When we get into rewarming,
Moist heat.
varies.
That's the key there,
Say it again.
right? Moist heat. When we're getting into rewarming, we got to get them really to that definitive level of care, and that they need a hot tub, as weird as that sounds, but that water bath of warm, really hot water is great, and we can't provide that in EMS, but, you
Yeah,
know.
absolutely. That and obviously make sure that we're following, because I know this is one area in which protocols do vastly differ.
Oh, yeah.
But so make sure obviously you're doing what you're supposed to within your own protocols. But if you do have options for rewarming, make sure that we are not starting that rewarming process if there is a potential of refreeze. That is going to cause substantially a significantly larger amount of damage moving forward from that. Couple more quick ones here to keep in mind as we're going along. As Will said at the top of the episode, it's the holidays, and while we say happy holidays, a lot of times at holidays can be some of the most unhappiest times.
Yeah.
We can see large amounts of increase in psych and alcohol related issues. We can see more injuries. Yes, we have our more significant injuries a lot in our warmer months, but knives, cuts, burns from the holiday meals, falls from ladders, from an icy roof trying to put the Christmas lights up last minute. Keep all of these things in mind when we are responding to these types of calls. And also remember, just because we are happy and celebrating the holiday of our choice, that might not be a happy time for somebody else. So we need to make sure that we're keeping that emotional intelligence about us, and reading what the situation is with that. Winter equipment. I know I work in a service up north. We have a survival bag,
Mm.
in case we were to go off road or something to that effect and become stuck. If that is a concern for you and your company doesn't have that, maybe look into doing something like that. Having some, I think we have a couple MREs, a couple water pouches, heat blankets, heat packs, a flashlight, those types of things. Just enough to get you through for a couple hours until help can get there. Again, maybe if you're in Texas or Florida or Southern California, you have no idea what I'm talking about, and that's fine. But for those where it applies, if that's not something that you have, but there's a potential, maybe that's something we look into. Also, remember our batteries. Um, so many of our different devices rely on batteries, and those batteries can lose their charge much more rapidly in colder temperatures. Maybe we're carrying an extra battery with us, making sure that we're carrying extra blankets. Listen, we get those blankets from the hospital. Those things are not thick or warm in any way, shape, or form. A single a single hospital blanket is not enough in a cold winter. Get
Mm.
two, three, four, however many you need per patient. Have a stack of them to be able to provide heat or the loss of heat from that patient.
Yeah.
Hot packs, throw a couple extra of those on the truck. Make sure you have some type of system in place to prevent your IV fluids and your meds to keep them from freezing and becoming damaged. Things that, especially on the newer side, say I know a lot of new EMT programs graduate either in the summer or the winter. So maybe this is your first winter coming into being a paramedic. These are things that maybe you didn't necessarily think about as an EMT, but now you have to kind of keep in mind and plan for. Do you work in an area where in the amount of time that you're walking outside from the patient's house to the ambulance that your IV fluids could freeze? those are all things that you have to keep in mind and be able to compensate for as well.
Absolutely.
And with that, Will, if there's anything that you want to throw on to the topics that we were kind of thinking about in the winter realm, go ahead and do that. But otherwise, I think we want to wrap up here with just the last couple little things that, again, could have been episodes, could have been quick crits that we just didn't have time to get to. But it's just these general things. I know we say almost every episode that we try and bridge that gap from what we don't get taught in medic school. And a lot of times we as a podcast, we as individuals try and do the deeper dives into some of these medical topics or pharmacological topics that we, again, truly don't have time for in paramedic school at times. But there are a lot more avenues that we can explore that from, as far as how we perform as a paramedic outside of a clinical aspect, but still within our job role. So, Will, if you want to take some of those there that we've talked about.
Definitely. I think again, Dan, we're just going to sort of rapid fire these things as we close. But what the heck did I actually learn in medic school? Because I can tell you what I didn't learn in a much deeper capacity. But a few things that I definitely didn't learn when I was going through paramedic school is how do you actually manage your emotions on scene? And oftentimes we're going to see this when we're communicating with different people, your partner, families, police, fire, all of it. One of the things that's got me further than anything else in my career as a paramedic and now more so as a nurse, you're going to meet a lot of different personalities and you're going to talk to a lot of people, whether it be a patient, a family member, like I said, police, fire, physician, any of it. If you come in with a calm demeanor, you get so much more accomplished. I think getting all excited and maybe angry if something doesn't happen or go your way is a natural response. But if you meet that with just a calm presence, people might really think about what they just said. Maybe you called a physician for an order and they said no. I always say when I'm on the phone, hey, no problem. We'll see when we get there. Not, I'll figure it out, not an issue. And that physician's like, actually, hold on a minute. Maybe you should do that. Maybe that's fine, whatever. Just having that calm presence really does so much good. When we're talking to families about really awful things that happen, try to avoid that high acuity medical jargon. And I know sometimes on the podcast we speak in what sounds like a different language, but I think we always try to bring it back down to that layman's term, which is really what we all should be speaking in. Sometimes you get a lot of letters after your name. I know I'm guilty of that, but I like to go to school, but that doesn't make me better or smarter or anything than anyone else. I like to just bring it back to how they know it. If I'm working something, just tell them really what it is. Hey, this medication is just going to try to get their heart started back up. Or we're doing CPR to get blood to the rest of their body. Just trying to get some blood through them. Make it really simple. You know, Communicate calmly and really with that, leading a scene. Be clear, concise, closed loop communication, and having that calm demeanor. I think one of the hardest things that I had to do when I was a new medic, and they never taught me how to do it in school, was manage a scene. Luckily, I had a mass casualty incident pretty early on into my
Luckily.
career. I guess not luckily, not luckily. Fortunately, everybody was okay. It was if there was ever going to be an MCI that was great to take command on, it was this one because it was all green tag patients. There wasn't anything
Beautiful.
high acuity other than the volume of patients. But it was great because it helped me understand like how do I manage a scene? How do I manage a difficult scene? And I think the most important part of that is managing the scene before you start doing any treatment. How many people are here? How many patients are here? Where do I take them to get triaged? Where do I take them to get treated? What resources are coming in? Having that leadership, understanding who to ask for certain things, where to go for certain things, and how to command a scene is going to be one of the most important things because it's not easy. You can train for it as much as you want, but as soon as things get crazy in the field, Dan, you know how it is. You know, it is really difficult to maintain a calm presence in chaos, but it's the most important thing that we need to do.
And I think, Will, on that note, I had a paramedic student, and we went to a house fire. a very large house fire, several, I think it was like a row home with several units involved. And we got to talking that, in her program that she had, and it made me reflect. I know we had in my program a day in which we talked about these operations for maybe a couple hours. I'm prepared for the collective groan that I'm going to get from this, but take an ICS class.
Yeah.
We all
Yeah.
have to have them to work. I'm not saying you have to go redo ICS 1, 2, 7, and 8. You don't have to go take 2, 3, 4, 5, 502, 601, whatever all these different ones are. I'm not saying you have to be some NIMS wizard,
Yeah.
but take some type of ICS course and actually pay attention, because there is a lot of structure that goes into these events that we don't get around to learning, because one, it's not necessarily our job in those larger multi-agency responses, that usually escalates up the ladder pretty quickly, in which we're kind of absolved from that from a field medic standpoint. But understanding how that process is going to go, understanding that you might be the first person there for the first 2, 3, 5, 7, 10 minutes, depending on where you're at, and understanding what those next steps are going to look like from the time that you get there and the time that additional help arrives, 5, 10 minutes later, whatever it may be. So again, I'm not saying you have to go take 1, 2, 7, and 8 over again and sit there and do them all from start to finish, but find some type of ICS type resource and give that another look. Talk to the fire departments. I know we've a common theme across a lot of our episodes is talk to the people that are involved in these things. When we were talking about OB, go talk to your OB nurses. When we're
Mhm.
talking about this type of stuff, talk to your local fire departments, talk to your police departments. Find out how they operate. Find out if they do anything, specific within, a multi-agency, a local multi-agency agreement, if there's a specific way that they operate, or how they expect you to operate and vice versa within different various scenes. I know when I first started at uh 15, 16 years old as a junior firefighter explorer, um we used to, once every couple months, we would have a joint training with our EMS, and that kind of went to the wayside as I kind of grew up in the fire department there. And that's not something that I see a lot of anymore. I'm not saying that we at an individual level can necessarily, immediately change this, but opening these doors for these conversations. Hey, I want to learn a little base about what you're doing. Hopefully, you would want the same, to learn a little base about what I'm doing. I'm not going to teach you how to be a paramedic. You're not going to teach me how to be a fireman. But let's have a base understanding on how we can work together to accomplish these scenes in the most effective way possible.
Absolutely. Dan, to close this episode out, I think one of the most important things that I never learned how to do in paramedic school, because one of the awesome things about being a paramedic student, and then again in nursing school, one of the really cool things, however, in nursing school, I did have to chart a little bit, because I think they wanted us to practice. It's a very important skill. But as a paramedic student, I never really had to chart outside of like the paramedic school's charting requirements. I never charted the way that I charted as a paramedic. When we document things, it's probably, and Dan and I have talked about this a ton, and I will tell anybody, I would be a paramedic for free. I love the job, but I really get paid to write my charts. That's the main reason I get paid. I would do this job for free if it meant I could go out there and treat a patient and not have to do any of the charting. But that's just not the reality that we live in. Everything comes back. There's always liability, there's always documentation, there's always reasons things need to be done. And paramedic school doesn't teach you how to document appropriately and clearly. It doesn't teach you some of these real world skills that you need, like we talked about earlier, listening to lung sounds in a loud ambulance or in a store environments. But on the charting aspect, one of my biggest pet peeves is seeing misspelled words in a narrative. And right up along with that, especially for those that use ESO, or any other form of charting, seeing an assessment documented somewhere in like a flow sheet that says you did your assessment at this time, and then seeing your assessment, your full assessment documentation done at another time, and they're supposed to be matching. it really grinds my gears. Find someone that knows how to chart really well and have them teach you. But you want to make sure that your narratives are spelled correctly. Sometimes you don't need to write the novel. You don't need to have a 10-page narrative. It just needs to be clear and concise and spelled appropriately. This kind of goes back to what we talked about earlier in the episode with professionalism. We are healthcare professionals. We're who people look to in a time of emergency to take care of their family member. With that comes a degree of responsibility after the call, that we chart that call appropriately, that we spell things appropriately, that we use the appropriate terminology when needed, and that things are concise and to the point. And along with that, making sure that your times are accurate. If you gave epinephrine at a certain point in time and then you document otherwise and they contradict each other in the chart, that's not okay. Making sure that things are done the professional way every time is the most important. Again, we get paid to write these charts. We get viewed as professionals. And as we want to get respected in the field and grow in EMS and get more medications and more interventions and more diagnostics, it's the little things that make the difference. I always tell people when I read someone's chart and it's misspelled and messy and it doesn't really flow correctly, how could I trust them with these high acuity medications if they can't do the small thing right? It all comes back to that. And I never really learned how to do it in paramedic school. I don't know if any paramedic school really teaches you how to chart appropriately, and everybody's going to have their own system. But find someone that does it a way that you think is right. But at the end of the day, make sure it's concise, clear, and please spell things correctly in the narrative. I don't know how many times I've seen the wrong there in a narrative before. I'm not saying you got to go get a degree in English. I really am not that good at grammar. Dan, you know that. But I try to make sure everything's spelled correctly. I might not put a semicolon in the right place, but my words and the proper use of there is
And
often done.
Will, on that note, Grammarly.com or Grammarly the extension. Number
Yeah,
one, if you're listening and want to sponsor the podcast, that'd be awesome. But this is free advertisement. I have had several. I'm not sure if this one preceptee listens or not, but she was a great EMT. She's continued to go on and do great things. She could not chart. She could not spell. And we sat down and downloaded Grammarly on it's free. Downloaded it on any device that she was charting on. And I actually talked to her, it's probably several months ago at this point. This was initially 5 years ago. When I talked to her a couple months ago, she goes, I still use Grammarly on every chart that I write. And I said, thank you. Because I agree that was is one of my pet peeves too. As we close up, I have one more thing. Well, you brought up ESO. I wasn't going to get on my soapbox, but I'm going to get on my soapbox for literally 10 seconds here.
absolutely.
ESO, if you don't know, is a charting software. We're not here to talk about, one charting software versus the other. I only bring that one up specifically because I know that one has an AI generating narrative. I don't know if others do. Maybe they do, maybe they don't. This is my own personal take. I have not talked to Will about this. I don't know exactly where he stands, although I believe I do. Please, for the love of God, do not use these AI narratives. It's one thing if you want to maybe use that to generate portions and then you continue to use that as a framework to build an actual narrative off of. However, the current state, at least the way I know it is kind of dependent on company, the way the company sets it up as well. But I know from what I have seen, not outside of the company that we used to work for, but another company as well, it's not good.
Yeah.
There's just no way around it. It's not good in the current state, and too many providers I have seen. While it is an immense time save, yes, but it's not a good product currently. I think there's a potential for it to be a phenomenal additional resource for us to use, but at least the way that I have seen it on two different companies, it's not there yet. So while I was very tempted to use that, I am also on the same page with Will where our narratives, our charts need to be appropriately done. And in my opinion, that was not completely appropriate.
Yeah, two things with that, and then we'll close out, Dan. One, if they give you the tool and you want to use it, by all means, do whatever you want. If you're going to use an AI generated narrative, please, I know that there's policies and everything. If it's AI generated, you have to say that it's AI generated for all legal purposes. And this podcast isn't to give any legal advice. Obviously, we're not giving any medical advice. Follow your protocols, follow your policies. But if you're going to use AI, give AI the credit. And off of that, the one thing that I will never give AI credit for, and I'm on the same page as Dan, I don't use the AI narrative because AI was not on the scene with me. It was the scene that I saw. For those of you listening and watching, you probably know how my brain works at this point and that it's very weird and funky. I will always say you can never get this with AI. My brain is weird. AI will never understand what the heck is going on in my brain. And so I write my own narratives because AI wasn't on the scene with me. My brain works in funky ways. And I've seen the AI generated narratives. I've generated them myself and then deleted them just to see what they would say about the call. And I've never enjoyed it enough. It doesn't work for my brain. Like I said, I got a weird brain. If you've been listening to the podcast for a while, you know that. But whatever works for you, just let it give the credit where the credit's due. If you're writing your narrative, put your name on it, put your cert number on it, put your degrees on it, sign it the same way you'd sign an email or something. And if AI writes it, give AI the credit. Say, hey, this was an AI generated narrative. Good for AI, good for whoever. And
But
it
at
does
the end
save
of the
some
day,
time.
that does still come back on you, whether it was AI generated or
Absolutely.
not. You are still ultimately responsible for the entirety of the content that it was generated.
Absolutely. And I think that just goes into using thorough documentation in your chart because AI is only going to pull from the data that you give it. And so if you want a really clean and concise chart, you have to write it yourself. Again, we're professionals. We need to at some point act the part.
Right.
And so with all of that, Dan, we covered a ton in this episode, but like this was a year in review. I think that we've grown so much of it as a podcast. I know that the listeners that have reached out to me have really appreciated some of the things that we talked about. And I really hope you appreciate some of the things that we talked about in this episode. We looked at some of the comments, we listened to some of the people that have reached out to us, and tried to throw a little bit of everything for you in this episode as we close out a kind of crazy 2025. So with that, I don't have much more. I'm going to let Dan close it out, but I want to thank all of you for really tuning in the last few months. We have so much to look forward to in 2026. We've got some great things coming. And I just appreciate it, all the feedback that you give us and the opportunity that we have to be able to publish these episodes for you to listen to on a monthly basis has really been one of the greatest honors and joys that I have going for me in life. I continue to work in healthcare, but my favorite thing is sitting down every single month with Dan, with some of our guests, and just discussing these topics. So thank you for that. Dan, why don't you have anything to close us out for?
I don't know that I can add much more other than just reflecting that I share the same appreciation, especially if you're still here listening. That means you've made it the whole way through that rant and ramble. But not only that, you've made it through this year with us, and we've watched this grow. We're starting to build a small community here, and I'm excited to take this community that we have and continue to grow and continue to learn together. Again, as Will said, I'm honored to be a part of that, and I'm excited to see where we're going from here. But with that being said, as always, remember, treat what you know, trust what you see, stay curious, and stay humble. See you guys next year.